decide on Prozac?
Well, I worked with Professor Hughes on it, and she kind of thought that that would be a good place to start since she hadn't been on something before. And this patient is a previous drug user, so we were kind of worried about what to pick and where would be a good place, like what would be safe to use with her. So, that's just kind of what she thought was a good place to start.
Okay, Lindsay?
My patient was already on 20 milligrams of citalopram, but she was still struggling keeping on her regimen for her diabetes, so that was all out of whack. And she was recently going through a divorce with 4 children, trying to control, keep her job, and it was just too much. So it was kind of an easier decision to bump her up a little bit for dosage.
What symptom drove you to do that?
Just the way she was talking about, with all her kids, she wasn't feeling motivated to even control her diabetes. So I thought maybe if we got that under control, everything would start falling into line when she, was in the right mindset.
Okay, all right. Good. All right, let's go through this case. This is a everybody should have a copy. 25-year-old woman, she comes to her PCP for routine physical exam. During that visit, she says, I've been feeling pretty down lately. I feel like giving up. Her PE is unremarkable. Her lab test, CBC, her serum chemistries, or TFTs were all within normal limits. Why would they draw those? Why would those in particular lab be done? Anemia could give her those symptoms. Okay, what else? Infection. Okay, what else? Pardon? Electrolyte disorders like what? What are you kind of thinking about? Hyponatremia make you tired. Okay, what else? Why the TFTs? Thyroid problems. So what kind? Hypo. Okay. Pregnancy test was done, it was negative. Her medical history is non-contributory. She doesn't take any medicines except she had Nexplanon implanted last year. So what is that?
Birth control?
Birth control, what kind?
Implantable?
Progestin only. She reports drinking 2 to 3 beers on the weekend, but denies any use of recreational drugs, including marijuana. She states that she has increasing periods of depressed mood I typed this fast, man oh man. Okay, or depressed mood over the past few months, and often finds herself crying in the morning for no particular reason. She reports no interest in usual activities or hobbies. She used to play the guitar, she used to run several times a week. She no longer does that. She quit 3 months ago, no longer reads for pleasure. She's engaged to be married in 3 months, but feels that she does not deserve to be his wife. She states this. Over the last 2 months, her appetite has decreased and she has lost 15 pounds. She feels overwhelmed with all the plans needed for the wedding. She states that she does not deserve a wedding as nice as the one that's being planned. She has difficulty sleeping. She can get to sleep, but she cannot stay asleep. And once she wakes up, she cannot fall asleep. She has little to no energy during the day, finds it difficult to concentrate or make decisions. This is a major concern for her because she's in graduate studies at a local university. Her mental status exam reveals an appropriately dressed female who appears sad but who's alert, coherent, and logical. Her affect is constricted, apprehensive, and sad. Mood is depressed. She admits having suicidal ideations, but she has no plan to end her life. She's oriented to ×3, but shows some recent memory deficits. Her intelligence is estimated to be well above average. Concentration and abstractions are satisfactory. Her responses are. She denies hearing voices or experiencing a visual hallucinations. She has good insight and judgment into her illness. Okay, so look that over and give you a minute or so. What signs and symptoms does she have that support the diagnosis of a major depressive disorder?
No interest in usual activities.
Okay, look, I'll go to you first when we take 1 minute, let everybody look through. Mark, you can mark on this, you can, I don't care if you keep it or not, and we'll start with Kendall. Sorry, Kendall, I should have. Some of y'all process faster than others. Okay, Kendall, start us off.
No interest in her usual activities and weight loss.
Okay, someone give me another one.
Lasted longer than 2 weeks.
Longer than 2 weeks, okay. Length, same,
Suicidal ideation.
suicidal ideations, what else? Jason,
Inability to stay asleep.
can't stay asleep. Yes.
Inappropriate guilt.
Guilt,
Worthless.
worthlessness,
Unable to concentrate on their decisions.
okay. Or diminished concentration, anything else?
No energy.
No energy, what was that, memory issues,
Sad.
sad,
Appetite down.
appetite's down, really down. 15 pounds in 3 months is a lot, a lot. Anything else? I think you hit most of them. So she's got a divorce or just depressed mood. She's got anhedonia, you've mentioned those. Frequent episodes of crying. She's got vegetative symptoms, a loss of appetite, and her insomnia, or energy, suicidal ideations, or feelings of worthlessness, inappropriate guilt, and her sad affect. Okay, so here are the drugs. So would you put her on a drug? Maybe that's the place to start. Does she have symptoms that a drug that would respond to medication therapy? That's probably one thing to ask yourself.
I think so.
Okay. What would be other option? So you could put her in therapy, okay?
Fix the sleeping.
Or you could address just certain symptoms.
Yeah.
But she presents with a fairly long list of symptoms that if we can kind of get her to respond to that, then probably we can, either therapy would make more sense or both. So in terms of what drug to choose, how do we choose between these?
Comorbidities.
Okay, comorbidities, but let me back up even further. So when we start with looking at what drug to choose or what class, we look at literature. So we look at evidence. Is there any evidence to say that one of these classes is better than another? There's no evidence to say SSRIs are better than another. So I think what I put in your handout was that they're all efficacious. There's no study that says head-to-head comparison that this class is the first place to go. Okay, different from yes.
No, I just want to say one thing, because I think that they said SSRI because it's so often listed as a first-line agent.
Right.
What she's saying is correct. There's nothing that says one's better than another. This might be clinical trial evidence has given this drug this indication, but it doesn't really say that the other drugs don't work as well. I think it's a fine point, a final point.
Okay. So there are some diseases where we have evidence that says this is the first drug, this is the next step. We don't have it here. So we've seen that some in psych, in this module more, where there is no evidence that says here's where you go first. So all things being equal, any of these could work. However, the SSRIs are preferred for what reason? Reasons.
Smaller side effect profiles.
Okay, one person say it. Side effect profile is more benign than others. If you compare them to the old agents like the tricyclics, what else?
No lethality for doing
Decreased lethality. Okay, for those two reasons, they have become they've become preferred. Okay. All right. So the preferred, the more benign, you mentioned that, minimal risk of lethal. So some other things we would look at would be, has she been on something before? There's nothing in the history that tells us that has experienced these symptoms prior, and so there was nothing there to guide us. When Amy came out today and said, okay, we were going to start this person on antidepressant, so one of the first things I asked her was, okay, has she ever had this before, and is there a drug she has used before? So you can use that sometimes as a guide, as a place to start. The other thing you look at is concurrent medical conditions, always, because those are your contraindications. So what are the big contraindications to SSRI? QTC prolongation with citalopram. Is there anything else? Okay, sexual dysfunction if you're thinking you're going to make it worse. So that's a side effect you would be aggravating. A side effect could aggravate that. What about the bleeding tendencies? What are those? What would you be looking at?
If they're also taking other agents.
If they're on like some type of anti-coagulant. Okay, that's really it. There isn't a whole lot. You kind of have to ferret it out as you read through those. Okay. So then you also look at potential side effects. So Mariah mentioned sexual dysfunction. What are the other big side effects that you would, or diseases or conditions you would look at the person having that you could worsen by the use of an SSRI?
Anxiety.
Okay, anxiety. So some of them are activating, so you would want to address that when you start the antidepressant. What else?
Dizziness, orthostatic.
Orthostatic hypotension. So if they were, now who might that be more likely to affect?
Older patients.
Elderly, okay. Diabetes with neuropathy could certainly do that. You can have a autonomic neuropathy that would lead to more orthostasis. Okay. Think, what's the big one? What are the big things that people complain about SSRIs right off the bat?
Sedation.
Nausea and sedation. Okay, so if they have a significant GI disease or condition, you may really want to think about that, what you choose. The other would be the daytime sedation. So what about for her? You think she'd worry about that?
Yes.
Yeah,
To
she's a
school.
student. You can't put her to sleep during the day. That'd be difficult. Ease of use. So does the drug fit in with what her lifestyle is? What's it cost? So will her insurance pay for it? And then does the patient have a preference? So those are all things that you would think about. Okay, so here are the products that we have for this patient. Here, you mentioned most of these, so QTC interval, concurrent anticoagulant, age, GI disease, sexual dysfunction. So you got those. Okay, so look at the profile up there. Take a minute. just look at it and see how you, based on the history that she's given you, does it lead you to one or the other? And there's no right answer here. Does anybody have a strong opinion about one of the drugs and tell me why? Just explain to the class. Zane?
I wouldn't say it's a really strong opinion, but I think out of the symptoms that she's having, the sedation, and she's already having trouble sleeping, I would pick escitalopram, the last one,
Okay,
because it is one of the least that's going to cause sedation during the day, and then her insomnia, it's least likely to cause her not to be able to sleep.
okay.
I think those are the two most important factors that she was dealing with.
Okay, so Jordan says she'll hear sexual dysfunction since she's getting ready to get married. Okay. What about her weight?
Yeah.
So do you want her to regain weight?
She probably wouldn't
I
want
know.
to.
Some are here going,
On
no.
a diet, but not on a pill.
Well, it depends on when you had your wedding dress fitted. And see. If that was fitted before she lost the weight. Okay, so you'd have to consider that. Anybody else look at that and pick another? What did it say about her sleeping? Or did it say anything about being tired during the day? Okay, so could anybody make a case for maybe going to sertraline? Yeah, well, a little bit more, yes, good. It's kind of in the middle. It's a little bit more activating, a little bit less sedating. I don't think you can go wrong here. I think fluoxetine would be a little bit harder for her, but I think you could go with any of the rest of them and start and try it. Okay. So what kind of patient education and time to follow up would be needed? What do you need to tell her about? If you picked escitalopram, then what do we need to tell her?
Not to abruptly stop the medication,
Okay, to not abruptly stop, and that would be for what reason?
just for withdrawal symptoms.
Prevent withdrawal, what else?
Can it get a little bit worse before it gets better, like the depression and stuff, or is that different?
Maybe educate if she is
Yeah,
having
if she
suicidal
has
ideations to.
Well, what do you want to know more, what would you want to know more about that? What would make you,
If she had a plan.
she doesn't have a plan, so I always ask about a plan. And the more detailed that plan is, the more concerned I usually am. If they thought about it and have no plan, I'm not usually as worried. Kendall, did you have something to add?
I was just looking at the time of onset, like improvement can take 1 to 2 weeks.
Exactly, so you really want her to know that. And did you all talk about, I don't know if we talked about, what symptoms are likely to, you could even tell her what you think will tend to respond first. Usually those vegetative symptoms are going to turn around a little bit faster, so she should start sleeping better, her appetite should start returning, okay? So it's really important to give them an idea of what to expect. People do much better that way than if they don't know. If she thought tomorrow things would turn around, then she would be very disappointed. Okay? When do you want to see her back? I hear a month.
Say a month.
A month, did someone say 2 months?
2 weeks?
Why the 2 weeks? What would be the reason to see her then?
Onset should kick in by then.
Do what?
It should have kicked in pretty much by then.
Okay, so we should start to see some. So it's a continuation, it's a continuum, so they will start to get better. I also feel like, if I remember right, 2 to 3 weeks is about the time when suicide risk goes up because of energy, okay? So I'd probably want to know that. Can you tolerate it? Sometimes patients will take a drug, they will not tolerate it, they will stop it, and they will not tell you until they come back. So having that in there would probably catch that. Or she couldn't afford it. Got to the pharmacy, it didn't get communicated, there was no drug, I just assumed you didn't, okay, you didn't care about it, so I'm going home. So all kinds of things drop, all kinds of balls get dropped. So I think a 2-week is good. My biggest drive for that would be the suicide risk, and then I'd want to know, how are you feeling now? What do you think about suicidal, what are your plans? Have you thought about harming yourself still? Find out about the plan. Then when should you start to see her back to assess for, to determine if the drug's being effective? Okay, somewhere probably in about 4 to 6 weeks, you should see a pretty good uptick in her response, her symptomatology going down. So that would be a good point, would be that 4 to 6 week mark. Okay, so she calls you in 2 weeks, and she says, I feel much better. I've been taking it every morning, and my sleep is better, my appetite is better, my outlook is better, little things don't bother me as much anymore. I think I could even do better. I'm less despondent, I feel as though my concentration's better, but I still haven't restarted the exercise regimen. I don't have the energy to do that. So she wants you to increase her dose. So what would be your response?
Wait 2 more weeks.
Say it again, Lindsay.
More time, just to see.
Probably not more time. She will continue to have, she should, since she's had a response, great. Then it sounds like she's tolerating it, so she should continue to respond. Some people will go ahead and up that dose, but if you do, you run the risk of greater side effects at that point. So some is just reassuring. Great, glad you're doing okay. We need to give this a couple of more weeks. Otherwise, we're likely to cause you some more problems. So that it would be mostly reassurance and then see her back in 2 more weeks. Okay. But you will see people increase the dose at that point. Okay, so she comes back at 4 weeks. And you ask her about the side effects. She recalls some nausea during the first week of treatment, but continues to take the medication. After breakfast, as directed, noticed that the effect went away about 3 or 4 days, after 3 or 4 days of therapy. Denies diarrhea, insomnia, or headache. Before leaving, she reluctantly admits that the only problem that persists is sexual. She states that she loves her fiancé but has no interest in having sex with him anymore. How would you manage this complaint at this time?
There's an adjunct you can give her.
So you can use adjunctive therapy. What would that be?
Is it MAO?
Not an MAO. Remember, we never use the MAOs and SRIs together. Buspirone. So Buspar. Okay, remember those adjuncts? So that one's a good one because it is, it's not a very effective on its own as an antidepressant, but it's very good and the one thing it's really good at is it decreases sexual dysfunction. So you could add it on. It is a serotonergic drug, so you can increase serotonergic side effects and you have that risk of serotonin syndrome with that. What else could you do?
Switch.
You could switch her. You could switch her to a drug that has less sexual dysfunction side effects. How do you think she would receive that if you told her that? She probably won't want to because she's responded well. She's doing well except for this area. So probably an adjunct at this point is a good thought. It does add another drug, that's the only thing. But it's low risk, and you've already got a drug that's effective, that she's tolerating well. So that would probably be the way to go. But you could switch her to a different agent. But you still got, then you've got that time frame all over again to go through. Okay, so at 12 weeks, she reports that her depressive symptoms are effectively in remission. I feel like myself again. Her energy's improved, she's doing well in school, she's looking forward to her wedding day, she's tolerating the drug well, sexual dysfunction is resolved with the changes made at the last visit. So how long does she need to keep taking the antidepressant? For at least a year. Remember that little chart I gave you, that's, what phase has she kind of completed? Acute. So what's the next phase?
Continuation.
Continuation. And the goals of continuation phase are what?
Eliminate residual symptoms.
Say it loud.
Eliminate residual symptoms and prevent relapse.
Right. So we want to treat her, and I think I put in the chart at least 9 months. So 9 to 12 months you would want to leave her on that dose. Then you could look at the end of that is whether to continue. So who did we in your handout go back and look at? Who did we say needed maintenance therapy?
Someone who's had multiple episodes, or like 2 before, what was it, 3 before 40, or 2 after 40 or something?
People less than 40 with 2 or more episodes.
Right,
Yeah.
so she's only had 1 episode, so at the end of that year, it would be reasonable to look at tapering her off. Some of this could be situational. She has a lot going on. She's in school, she's getting ready to get married, so lots of things. It could be some of just that reaction to that. And if she can go through therapy and learn some skills to cope with the next time she encounters that kind of stress, she may do okay without ever having to be treated again. If she had another relapse, then that would be a time to consider maintenance therapy. Okay, does that help? Is that what you wanted, Dr. Britton?
That's what I wanted. That's very good.
Thank you.
Thank you.
You're welcome. Are you finished with them?
No, I'm gonna go over the S-BERT for Friday.
Okay.
And
Let me just, while he's coming down, I have seen the evaluations. There's only 13 of you that have responded. They're really helpful to me. You brought up issues that I need to consider the next time. I consider everything you've said very thoughtful. Those of you who have not responded, I would ask you to do that. Look at some of the things we did that maybe are different from other modules and comment on them. Like the objectives, the handouts for the guest speakers. What else do we do? The PBL has probably gained the most comments, and a lot of it goes to organization of that. So I got it. I got it. Those were very helpful. But anything you tell me is good. You reinforce what I do, that's great, but I really need to hear about things that don't work and what you think would work better. So I would like to hear from more of you. And I appreciate everybody's taking the time to do that. It's really helpful. Okay. I'll see you all Friday. Those of you who I did SPBL and I graded it, you can come by. I don't know how much longer I'll be here today, but I'll be around tomorrow. Or you can do it next week or email me and say, can I come at this time, if this week doesn't work. You're welcome. I did. If you think it's a 7 minutes, I can do it.